Everybody, we're going to get started. I'm Praveen Akathoda from Pulmonary and Critical Care. It is my distinct pleasure to introduce our Division of Pulmonary and Critical Care Medicine visiting professor, Dr. Njira Lugogo, who's a professor of medicine at the University of Michigan, where she runs the asthma program, where we interact a lot as fellow asthmatologists. So we've been good friends over the last several years. It's actually fun because this is my second of 3 times introducing her for talks this month. I got to introduce her for a plenary at the Aspen Lung meeting 2 weeks ago. So that was a lot of fun too, where she gave a spectacular talk, which I'm sure this one will be as well. Njira did her training in fellowship for pulmonary and critical care at Duke, where she had her initial faculty appointment and started a asthma clinical trial program in asthma clinical research there, and was recruited to the University of Michigan several years ago, where she has quickly built a incredibly impressive both clinical research program and clinical program. She's known internationally as an expert in asthma clinical care and in clinical trials, particularly in our new generation of biologic therapies, which you'll hear some about today. I call her when I need advice, not just on patients, but on life and career. So, I'm sure she'll offer that to you as well if you ask. So thank you so much for making it all the way here to San Diego.
Thank you so much. I'm really very honored to be here. I've loved the campus. I decided to walk this morning, so I got to see the library and the very interesting engineering building. So it's very beautiful. Thank you for having me. I'm hoping that at the end you'll have a lot of questions. I'm also hoping that you'll leave with a few thoughts about how we might revolutionize asthma care in 2023 and beyond. So let me see. I'm going to try to advance the slides here. I chose this topic because there really is a lot going on with asthma care at this point. We've had some therapeutic advances, but we now really need to achieve paradigm shifts, which are quite hard, frankly, to accomplish. And I'm hoping that at the end of the talk today, you'll be very excited about what we have in store for our patients with asthma. So these are my disclosures here on this slide. So today I chose to talk about asthma pathophysiology and phenotypes. I think that's critical in understanding the underlying pathology of the disease, because we now have a lot of targeted therapies. I will then go on to talk about how our understanding of asthma pathophysiology can advance care. So we are really focused on risk mitigation and stratification, looking at how inflammation informs us about asthma risk, looking at exacerbations. We previously focused a lot on control, looking at new anti-inflammatory reliever strategies and focusing on that. Very little on biologics. Biologics is a talk in and of itself. I am giving pulmonary grand rounds tomorrow. So if you're really excited about biologics, you can join. I'll be happy to go into a lot of details there about biologics. OCS toxicities, embracing OCS sparing in asthma care. It turns out that asthma and COPD result in probably 70% of the oral corticosteroid exposure that our patients have. So we are very good at giving people oral steroids. And then targeting treatable traits. And finally, I'm going to end with a concept many of us are beginning to embrace, which is remission in asthma care. Something I frankly never thought I would see in my lifetime, but something we are really starting to feel is actually feasible. So, if you read the textbooks, you're going to see information about asthma being described as a chronic disease characterized by recurrent episodes of symptoms, related to reversible airflow obstruction. And the hallmarks of the disease are actually bronchial hyperresponsiveness and airway inflammation. Now, it turns out that not everybody is reversible. Unfortunately, some people have fixed obstruction. Some people have preserved lung function and they don't have a lot of obstruction. Some people have a lot of inflammation and not as much hyperresponsiveness. Some have a lot of hyperresponsiveness, not as much inflammation. So the definition in the textbooks really sort of makes asthma seem like it's a homogeneous disease, but it's actually quite heterogeneous in its presentation. And it's a complex disorder with distinct pathophysiologic mechanisms that contribute to the clinical signs and symptoms you see when you're managing patients with asthma. So what does that mean? In a normal patient, your airway epithelium looks quite good. You have your cilia there. You have your epithelial cells, which are not disordered. The subbasement membrane looks quite normal. And you don't have inflammatory cells in your submucosa. Now, the patient on the right is a patient with mild asthma. And so even in its mildest form, you start to see changes to the airway. With a denuded epithelium, the cilia don't look normal anymore. You see mucus gland hyperplasia. The subbasement membrane is thickened. And now we have inflammatory cell infiltration in the mesenchymal area. And knowing that this is ongoing, even in the mildest form of the disease, is really important when we start thinking about how we should manage patients with asthma. So there are some common asthma phenotype. The ones you've probably heard more about are the type 2 asthma patients, those who are allergic, eosinophilic, or both. And then the non-type 2 patients who might have obesity-associated asthma or asthma that's polygranulocytic, meaning there's not much inflammation. It's mostly airway smooth muscle modulated with airway hyperresponsiveness and smoking-related neutrophilic asthma. So this, this is known as a confusogram. I guess people call it a confusogram, but I look at this a lot, and I would encourage you to pull this out and put it somewhere next to you and visit it often, because really what you're targeting in patients with asthma in the form of inflammation are multiple pathways. And what we know about inflammation is it's dynamic. So it changes. Asthma is a disease that's driven by triggers and exposures. So you might have a person who's not generally terribly eosinophilic, who's quite eosinophilic after a viral illness or environmental exposure. You can have one dominant pathway or multiple pathways. The pathways are somewhat redundant and they can be variably activated. In general, you have your allergen-induced inflammatory pathway, and you have your non-allergic eosinophilic pathways, which are driven by alarmins like TSLP, IL-33, and IL-25, which cause ILC2 production of IL-5 and give you eosinophilia. And then you have TSLP, which is one of the alarmins that is produced by epithelial injury, causing downstream inflammatory factors. And then we have the patients who have mostly structural inflammation, where the mast cells and the fibroblasts cause collagen deposition and airway remodeling. And you can see that the triggers are variable. So you can have specific and non-specific triggers causing inflammatory responses. Now, in order to understand inflammation, we use biomarkers. I sort of think about our colleagues in the COPD space. They've done a lot with imaging. We haven't done quite as much with imaging. We are now, extending our outcomes to imaging. And now they are sort of coming more towards inflammation. And asthma is one of the diseases in pulmonary where early translational work is now becoming something that we use in clinical practice, because we understand what the inflammatory pathways are. And so if you think about biomarkers, they're either diagnostic, they help you diagnose disease, understand the underlying pathology. They're predictive, so if you have biomarker X, you have a better treatment response, or they're prognostic, they pick out the people who are unlikely to do well. And so the definition then is a characteristic that can be objectively measured and evaluated as an indicator of normal processes, pathogenic processes, or pharmacological response to a therapeutic intervention. And so we have a couple of biomarkers that we use in asthma care. Now, the most common one is the peripheral blood eosinophil. And if you leave here with only one message today, it's please check eosinophils on your patients with asthma. And I'll tell you a little bit about how eosinophils are predictive of poor outcomes in patients with asthma. And that's primarily an IL-5 driven process. We can also measure exhaled nitric oxide. It's not quite as widely available, but nitric oxide is produced by induction of INOS, which leads to increases in exhaled nitric oxide. And you can measure that in the patient's breath. And that's really driven by IL-13 and IL-4. So if you see eosinophils, you're thinking there may be an IL-5 component and IL-4 and 13 with nitric oxide. So why does it matter? Now, Gina actually has a pocket guide, and this is more utilized in the severe asthma space, but even on the milder end, eosinophils are predictive of poor outcomes in patients with asthma. And so you can see that their definitions of what eosinophilia is, that's an absolute count. So you take your count and multiply by 100, your absolute count to get that total eosinophil count. Sputum eosinophils tend to be a research tool, very hard to obtain clinically. Your nitric oxide levels there, and then clinical factors that are predictive of asthma outcomes. And not all patients have all these factors. So it helps to really get all the information on all the patients. So nitric oxide, just real quick, is produced by the epithelium. It's primarily regulated by IL-13 and IL-4. It can be increased in people who have atopy and allergic rhinitis in the absence of asthma. It is a good biomarker for IL-4 and TSLP targeted therapies, and it's impacted by a variety of our biologics. Now, in the absence of concomitant inhaled corticosteroids, having a high nitric oxide of 50 parts per billion in adults really predicts a very high likelihood of having corticosteroid responsiveness. And so I use this in my clinical practice with my milder, quote, milder patients, where I talk to them about, you have ongoing inflammation despite the fact that you're not having a lot of symptoms. And that means you're at risk of having worse outcomes from asthma. And we really should treat those with anti-inflammatory reliever strategies. So how about biomarkers? This is just a quick slide. IgE, by the way, is not predictive of any asthma outcome. It's really meant to understand whether a person has particular upregulation of inflammatory pathways, and it's used to dose omalizumab, but it does not predict any other outcomes. So now we are going to look at implications of inflammation on asthma risk. So this is a study that was published in 2015, and it's a database study looking at patients in the UK and looking at their eosinophil counts in categorical fashion, and then determining what happens with these patients. And you can see a dose response effect. The higher your blood eosinophil count, the higher the severe exacerbation rate, the higher the acute respiratory events, and the lower likelihood that you are to have good asthma control. They created an eosinophil algorithm. This is a busy slide, but it's meant to highlight how you might define eosinophilia in a primary care or subspecialty care cohort. So what they did here is that they defined people as most likely eosinophilic if their eosinophil count was more than 300. And if it wasn't, they were on concomitant anti-IL-5 therapy. And if they didn't have that, they were on maintenance oral steroids with an intermediate eosinophil count, or they had an intermediate eosinophil count with nasal polyps. If a patient has nasal polyps, they're most certainly a type 2 inflammatory phenotype. That's one of those pathognomonic findings. And then if you had intermediate eosinophils Without all the other factors, you are likely to be eosinophilic. If you had nasal polyps or adult onset asthma, most of those patients are eosinophilic. You're likely to be eosinophilic. And if you had a low eosinophil count, nasal polyps kind of put you in an eosinophil category. And the reason this was done was to identify the prevalence of eosinophilia in a primary care population. And what you can see highlighted here is if you just focus on the most likely and likely patients, you're already at 70% of the patients being eosinophilic. So if you're not checking eosinophils, you're missing. Did the sharing stop? Sorry, that's okay. Yeah. Okay. All right. Perfect. And so the prevalence of eosinophilia is quite significant in a primary care cohort. Okay, and then here we're looking at the implications of eosinophilia. So in people who are symptomatic, the red bar and the other bar shows the most likely eosinophilic. All right, and then when you look at people on the basis of severe asthma, the more severe patients have a higher prevalence of eosinophilia. And then if you look at the impact of eosinophilia on outcomes, remember grade 3 are the most likely eosinophilic, you can see that they're more likely to be on high intensity treatment, that's GINA 5. They're more likely to have difficult to treat asthma, poor symptom control, exacerbations, hospitalizations, and ER visits. And so eosinophilia is actually quite consequential in asthma care. Now, how about nitric oxide? This is in a severe asthma population. And what you're looking at here is a post hoc analysis of the placebo population versus the dupilumab population in a phase 3 study. And what they did is they divided the patients and looked at what happened to their FEV1 over the 1-year duration of the trial. So the two green lines are the dupilumab patients. And you can see that those patients really didn't lose much lung function over the 1-year study, despite having a FeNO exhale nitric oxide level of 35 or normal. On the other hand, the red lines, what you see is that the patients with a high nitric oxide level of greater than equal to 35 parts per billion that received placebo in the trial had a loss of almost 120 mLs in lung function in 1 year. And just as a reminder, the number of mLs of loss in lung function for a normal patient is about 20. So that's quite a significant decline. And if that happens year over year, these patients are going to have very low lung function over time. And so now we'll talk about risk stratification. We share the chest with our cardiology colleagues, so I think we should adopt some of their practices. And one of the things they've done quite well is that they've taken a lot of large population health studies to identify risks for patients developing cardiovascular disease. And then they've developed risk stratification scores and calculators. Many of you have probably used those in the clinic. And when patients come in at a particular age, you plug in their cholesterol and their weight and their smoking history, et cetera, and out pops a score that tells you what the likelihood of a cardiovascular event is for the patient in the next 10 years. And that informs your decision-making. So what we don't do in that instance is say, well, your risk is high, but why don't you come back after you have your first MI and then we'll start you on some appropriate treatment. What we do is we say your risk is high. We know your cholesterol falls into that, your lack of exercise, your smoking, your obesity. We provide preventative strategies to prevent exacerbations. What we do with asthma is I come in, a new asthma patient. I'm not complaining. Most of them don't complain very much. And you say, well, you have asthma, so you don't have a lot of symptoms. Take this albuterol inhaler. Let me know if something happens. if you have an attack. And I'll show you that the consequences of that strategy is not benign for many patients. And so what we want to do is now start taking our biomarkers. We know eosinophils increase your risk of exacerbation. We know nitric oxide does. Pair those with clinical factors, come up with the risk stratification score, and be able to pick out high-risk patients that really require T2 targeted therapies. And so this is something that's been developed. It's called Oracle. It's not being used in clinical practice yet. They're really trying to work on looking more at Oracle. Now, this is in a clinical trial population, but what you can see is that if you have low eosinophils and really low nitric oxide levels and an absence of particular clinical risk factors, which I'll show you, and you didn't have an asthma attack in the last year, you're like in the really low risk category. The red patients over there who have almost 3 times the risk of exacerbations are people with high eosinophils, high nitric oxide, getting high intensity treatment. They've had an attack the last year, and they have clinical risk factors, which include poor symptom control, low lung function, issues with adherence, overusing your inhaler, intubation, ICU care, particular comorbidities, and environmental exposure. So we have an opportunity perhaps to actually look at our patients on an individual level to figure out what their risk is and then mitigate that risk and not wait for exacerbations first to happen. And there are a number of asthma assessment tools. I'm not going to go into great detail today, but it turns out that clinicians are pretty poor at picking up whether someone's asthma is controlled or not. And by the way, patients are pretty poor at picking up whether their asthma is uncontrolled or not. And so it's always good practice to actually use a standardized questionnaire every time you see the patient. I use the ACT. I am in the process of transitioning more to the ARQ. And the ARQ has questions about exacerbation history built in, and it has a predictive value that helps you to actually pick out the patients that are likely to exacerbate in the future. So I think that is probably going to be one of the main questionnaires that we use for asthma. And so this is what the ARQ shows you. This is a questionnaire. You see the 10 questions, very easy. The patients can do this in 3 to 5 minutes or less. And then at the bottom, there is a little scale that shows the patient what their ARQ means. So are they in the red danger zone, or are they in the green zone where they don't have to worry as much about risk? And the ARQ actually perform better than the ACT, because in people who are well controlled, which is an ACT score greater than 20, 31% of those people actually had suffered an exacerbation. So that questionnaire, because it doesn't incorporate exacerbation questions, is focused more on control, and it may not be picking up risk. And more importantly, depending on what your ARQ score is, green being well controlled all the way to very poorly controlled, your risk of exacerbations actually differs quite significantly. So even just incorporating an eosinophil count and a questionnaire in your clinical practice might help you to pick out the patients that are high risk. So now we're going to talk about exacerbations. It turns out that they are consequential events. This is a study where people were followed for 20 years, and the highest exacerbating group lost lung function the fastest. Now, whether people who exacerbate more are a phenotype that are going to lose lung function quicker, we don't know, but there's certainly an association there, and all of us can agree we don't want our patients to lose lung function as much as possible. So this is our current asthma treatment paradigm. We don't check biomarkers on anybody. We don't know who's high risk and who's low risk. We sort of treat them the same way. We just sort of say, well, you're okay, just take this albuterol inhaler, call me if you need me, you know. And then when the patients present with very severe symptoms, an exacerbation, an ER visit, a hospitalization, got prednisone, we start now to treat them appropriately to mitigate future events. Now, unfortunately, what I see in the severe asthma clinic is what Simon Colliard and Ian Pavard call people remodeling. The patient comes finally to the asthma clinic, low lung function. they've missed a lot of work, they've stopped working, they have corticosteroid-induced comorbidities, they've been hospitalized, they are depressed, they are anxious, and now we have this situation where even when we improve the asthma, the unintended bad consequences are quite hard to reverse. So what we are really looking for here, and this is that paradigm shift I was referring to in terms of how we approach asthma management, is let's use our biomarkers, figure out who's high risk, who's low risk. Let's not over-treat low-risk patients, but let's aggressively treat high-risk patients. Let's identify people who are likely going to go on to higher lung function decline, more exacerbations, more oral steroid exposure. Let's intervene early and increase the chance of achieving remission, although most of the time it's remission on treatment. But we want people to have a very normal level of function, good lung function, and good quality of life. And so if you think about things here, this figure always speaks to me quite a lot because, you know, our first bronchodilators were first used in the 1950s, and so was oral prednisolone. And yet in 2023, our most frequently used drugs for asthma are the short-acting beta agonists or SABAs. So we've made a lot of progress. You know, Praveen and I participate in clinical trials. We've been so excited. In the 80s, we had our first inhaled corticosteroids. In the 2000s, we had our first ICS LABA combination therapy. We've had our first biologic in 2003. In 2015, we got our LAMAs. We got the anti-IL-5 therapies, shortly followed by anti-IL-4/13 therapies in 2018. 2020, we got triple therapy. Now we can give people ICS LABA-LAMA in one inhaler. And in 2021, we got anti-TSLP therapy. And in 2024, we'll have ICS SABA in one inhaler. So we have a lot of drugs. Now, unfortunately, we continue to give people a lot of SABA, particularly as monotherapy. And you can see that there is enough data now to hopefully convince all of us that that strategy is not what we want to embrace going forward. So if a patient fills more than 3 canisters a year of short-acting beta agonists, they start to have a double the increased risk of emergency room visits. That was shown in that Sanford publication 2012, in publication in 2020 in ERJ. You can see that despite background therapy, these patients are on GINA steps 1 through 4. Those are people who are all the way from on no therapy, except SABA, all the way to medium dose ICS LABA. You can see that the more short-acting beta agonists you use, the cut point is about 2 canisters. Your odds ratio of having an exacerbation starts to increase. Males, adolescents, and older patients are more likely to overuse short-acting beta agonists. Now, we happen to have a drug that is very impactful on reducing asthma mortality, which is inhaled corticosteroids, but our patients don't use those drugs. They don't make you feel well right away, and a lot of patients don't really use those medications. And if you use more than 6 canisters a year of ICS, your mortality reduces by 50%. If you have a patient in your clinic asking you for 2 SABA canisters a month, you should be very worried. That person is highly likely to die of asthma. And if the threshold is really 1 a month, you start to see an increased risk of death from asthma. And the mortality rate is, you know, if you're looking at people who are all-cause mortality, is 2.3. The odds, the hazard ratio is 2.3 if you get to that 11 canisters. If you get to 11 canisters, your asthma-related mortality is 31 times higher. And if you get to 11 canisters, your respiratory-related mortality is 6 times higher. And you can see that right about 2 canisters a year, which is a couple of puffs twice a week, you start to see an increased risk of not only exacerbations, but mortality, including non-respiratory mortality. And many of our asthma patients actually die of cardiovascular disease, as it turns out. This is our national asthma mortality rates, despite all the progress we've made. You can see that we had a slight decrease in mortality back in 2001 up to about 2006. It's been relatively flat. In 2020, we actually went up from 3,500 to 4,100 deaths per year. And if you're an African-American woman, you're 5 times more likely to die of asthma. So there are significant disparities in asthma death rate as well. And short-acting beta agonists lead to some of these complications. One of the most common questions I'm asked is, well, is it the SABA use, or is it the fact that people using a lot of SABA have more severe disease? And what I'm hoping to convince you is that it is the SABA use, because it turns out if you use SABA regularly, you get beta receptor downregulation to the extent that you have almost no beta receptors expressed on the cell surface, and the drug actually doesn't work anymore. In addition to that, you have loss of functional antagonism. You get more bronchoconstriction. Those patients will always tell you, my chest is always tight. And in fact, beta agonist overuse gives you airway inflammation. And it also increases the risk of poor outcomes related to asthma. And so it makes sense to actually embrace an anti-inflammatory reliever strategy. Now, if you use short-acting beta agonists in the presence of an ICS, these would be done concomitantly. If you don't have it in one inhaler, the patient puffs the SABA and puffs the ICS right back to back. And the ICS itself actually has non-genomic effects that occur within minutes. It amplifies beta agonist-induced bronchodilation. It prevents beta receptor downregulation. It reduces bronchiovascular blood flow, reducing airway wall edema, and begins to suppress immune mediators. And then within 4 to 24 hours, you get the genomic effects, which is reduction in pro-inflammatory gene transcription, upregulation of anti-inflammatory gene transcription, and beta receptor gene transcription, making your beta agonist actually work much better. And so binding these two medications together makes a lot of sense. And you can see a transition in how GINA approaches this. So this is back in 2006. And what you can see in 2006 is they started to embrace this idea that rapid onset reliever therapy coupled with ICS is something we ought to do in asthma. And the statement you see here is, if a combination inhaler containing formoterol and budesonide is selected, it may be used for both rescue and maintenance. This approach has been shown to reduce exacerbations and increase asthma control at relatively few doses of treatment. And so this is what's been going on when it comes to SABA. So in 1995 to 2000, the first GINA report came out. In 1997, the first publication came out recommending the use of ICS-LABA therapy in asthma in general. Between 2001 and 2013, you see initially ICS-LABA embraced for persistent asthma. 2004 to 2007, you start to see maintenance and reliever therapy using formoterol containing medications for both. In 2006, I showed you the recommendation that was based on 3 studies showing that maintenance and reliever therapy is a superior approach. In 2014, they recommended regular ICS as an alternative option in step 1. Step 1 patients used to be SABA monotherapy. In 2018, they added maintenance and reliever therapy. And in 2019, you can see they came out with a very strong statement here saying the treatment of asthma with short-acting beta agonists alone is no longer recommended for adolescents and adults with asthma. So there's been a huge change in our thinking about short-acting beta agonists. And so this is 2019. You can see across the bottom now. I'm going to focus on step 1, as needed ICS formoterol, or low dose ICS whenever SABA is taken. And then the preferred strategy was ICS formoterol for rescue and maintenance therapy. And so what does that actually mean? Good asthma therapy is critical. These are the core things all of us should be doing: confirming the diagnosis, looking for treatable traits and risk factors that we need to correct. Inhaler technique is critical. Many patients don't know how to use their inhalers. I think many of us here actually don't know how to use the inhalers either. to be honest. Many of us don't know how to use the inhalers because there are multiple inhalers on the market. Each one is used a different way. And so teaching inhaler technique is very, very difficult. And you should have at least somebody in your clinic that can teach the patients how to use an inhaler. Talking to them about adherence. Adherence is pretty dismal. Most people pick up their medication right before or after they have an exacerbation and not ever again. And in fact, only half the people who are discharged from the hospital with asthma even pick up their oral corticosteroid prescription. Treat modifiable risk factors, and then you need to assess exacerbations, lung function, symptoms, and you sort of do this repetitively over time. So this is from 2022. Now in 2023, they actually added more drugs. I don't know if you've seen this. This is a really nice reference tool we use in the clinic, because if your patients are like mine, you ask them what they're using and they say the red inhaler with the gray cap, and I'm like, I have no idea what that is. And so having the ability to show the patient the inhalers helps them to be able to at least tell you what they're doing. But we have dry powder inhalers, we have soft mist inhalers, we have meter dose inhalers, we have the hand inhaler, we have the ellipta devices, we have all the biologics down there at the bottom. And, you know, oftentimes even with the best intentions, I give a patient education on the discus and they go to pharmacy, it's not covered. And they hand them the ellipta device with no teaching at all whatsoever. So we really do have a major problem. And whether or not a patient gets like 20% of the drug or 80% of the drug into the lungs is highly dependent on technique. Many people making 4 to 6 critical errors. You have to hold it a certain way. They shake things they shouldn't shake. They store it in a moist environment. They use it too long. There are just so many mistakes that can be made. So we really need to embrace inhaler teaching. And so this is what we have currently for asthma and COPD: 6 SABAs, 2 LABAs, 9 ICS inhalers, 5 LAMAs, 4 combinations, 8 ICS LABAs, 2 triples, and 6 biologics, and more to come. So we are really like, we have an embarrassment of riches in terms of drugs that we can give our patients. Our patients want immediate relief. So if when they are asked, they believe there's no need to take medications every day when they don't have symptoms. And they want a medicine that's going to work immediately when they do have symptoms. So, you know, this perpetuates the thinking that SABAs are the most important drug. They work right away. And our patients actually increase their maintenance therapy when they increase SABA. So you can see when they're well, they're using neither. But as you start to escalate your SABA therapy, you start to escalate your maintenance therapy. That's what our patients are doing. And that works for some therapies, but not for others. And this is some work we did that shows you that within 30 to 15 days prior to an exacerbation, only 14% of people filling their SABA and 18% are filling their maintenance. But once the exacerbation starts and they see a deterioration, those levels go way up. So our patients are not taking their medication on a regular basis. And you have to ask them about that in a pretty non-judgmental way, something to the effect of, I know it's very hard to consistently take your medication. So how many times in a week do you take X, you know, because I know it's very hard, and you'll be surprised by the responses. Or sometimes you prescribe the biologic and the pharmacy sends you a message and says, this person has not filled their medication for 6 months, which is a little embarrassing since the patient just told you they take it every day. This is a summary slide just showing you the significant impact of anti-inflammatory reliever strategies when you compare it to SABA across all severities. So the first set there, maintenance and reliever, they are comparing different combinations of budesonide and formoterol plus SABA versus using the same drug for maintenance and reliever. And the reduction in exacerbations is somewhere from 24 to 54%. If you're comparing it with SABA monotherapy, that's the gray bar there, 64% reduction in exacerbations. And if you're comparing it to budesonide plus SABA rescue, they still a superior effect of the anti-inflammatory reliever strategy. Giving the medication when people have symptoms is critical because they often need that medication at that time for both bronchoconstriction and inflammation. This is the Mandala study from last year, and they took a fixed dose combination albuterol-budesonide rescue inhaler, and they overlaid it on people who are already on maintenance. So they were either on low dose combination, medium, or high dose combination. And the impact was more significant on the lower dose ICS, but there was an overall 27% reduction in exacerbations, even in people on standard of care therapy. And these patients were actually quite adherent, which because they were in a clinical trial, and many of our clinical patients are not quite as adherent. And so in 2023, what I would like to highlight here is that the reliever has completely changed. And so for track 1, which is the preferred track, that's going to be your ICS, low dose ICS formoterol as needed on top of ICS formoterol therapy across all levels, whether you're taking it twice a day or as needed. Track 2, those are the patients that you have to be quite convinced are adherent on their background therapy. And the ones that are taking only SABA need to pair it with ICS every time they take it. And then here you have as needed SABA or as needed ICS SABA. And they still prioritize ICS formoterol because we have much more data on exacerbation reduction. But what you can see here is that we are not giving people SABA monotherapy anymore at least as of 2023. So when you go back to clinic, look for those people and start transitioning them off that strategy. In 2024, the ICS SABA inhaler will come on the market in January, and it'll be available in a fixed dose combination, but you can achieve this with 2 separate inhalers. You just have to be confident the patient will do it that way. And so people start worrying that if you give someone fixed dose combination, SABA budesonide on top of maintenance, you're going to give them too much steroid. All our patients are very concerned about too much steroid. And we presented this work at ATS, and we've now published this recently. And what you can see is that if you assume, you can tell how many canisters a patient has filled of SABA. This is in a claims database. And then you assume that for each SABA, they would have taken 80 micrograms of budesonide, because that's the dose in the fixed combination. And you add it now to their fluticasone equivalent exposure, that the green bar, the upper limit of the DPI, that's the FDA approved upper limit. You can see that all the patients are well below the upper limit of safety. So there are really no safety concerns about exposure. And in the clinical trial itself, they did not see any adrenal suppression. And so patients on average took about 8 puffs when they were sick. Some of them took none, some took 1 to 2 or 3 per day, but there was really a clear increase when people got sick, and they actually also had a concomitant reduction in OCS exposure with this strategy. And so when you're going to do this in the clinic, if you have somebody who's has a high symptom frequency, they probably should be on a combination therapy unless you believe the symptoms are non-asthma related. You want to have a maximum of 12 puffs a day. That's the maximum dose. You should advise them to take 1 to 2 puffs as needed up to the maximum dose, either by itself or in combination with what they were taking. If you want to use ICS SABA, you should advise them to take it at the same time. Don't combine ICS formoterol with ICS salmeterol. Like, you cannot combine different regimens. We don't know what the safety risks might be with combining 2 LABAs in one patient. And then if they're uncontrolled on ICS LABA plus SABA reliever, you can consider switching to anti-inflammatory reliever before increasing the inhaled corticosteroids. Now, the one group that really is at risk are people who are poor perceivers. They're sitting there, they never complain, they have high eosinophils, high nitric oxide, but they really don't perceive that they have a problem. Those patients may get into trouble with bad exacerbations, and they're unlikely to use their medication when they need to. So those might be people you have to educate and follow closely. So how about triple therapy? I told you we had multiple LAMAs on the market. It turns out that adding a long-acting antimuscarinic improves exacerbations by roughly 15 to 20%, sometimes more than that. And so if you have an exacerbating patient, you could go to add a LAMA to their ICS LABA, and you also will have an improvement in lung function and better asthma control. I'm not going to talk as much about biologics, but this is just to show you where our drugs work. This is omalizumab, anti-IgE, mepolizumab, reslizumab, anti-IL-5 antibodies, benralizumab, anti-IL-5 receptor antibody. Dupilumab blocks IL-4 and IL-13. And then tezepelumab, which blocks all the upstream mediators, the TSLP. So when you're giving a patient a biologic, you're probably not starting the biologic, but you're receiving the patient on a biologic, or you're referring them for consideration. You're really looking for several things. You want an exacerbation reduction, you want OCS sparing, you want better achievement of asthma control, you want better lung function. It may or may not happen for everybody. You do want to reduce ICS, and you want the patient to generally have a good quality of life. Our biologics are now actually targeting multiple diseases. T2 disease might be multi-organ. So, you can see dupilumab is now indicated for dermatitis, chronic rhinosinusitis with nasal polyps, EOE, omalizumab, asthma, nasal polyps, and urticaria. Our IL-5 drugs, mepolizumab, EGPA, HES, nasal polyps. So the drugs are starting to treat multiple indications, and they've gone way down, some to up to 6 months old, depending on the medication. And so how about oral corticosteroids? We use a lot of it. 3 million people per year fill more than 2 oral corticosteroid prescriptions per year. And you can find San Diego on the map there and see where you stand in terms of oral corticosteroid prescriptions. It turns out that the more short-acting beta agonists you use, the more oral corticosteroids you're going to end up receiving. So the light blue bar are people on SABA only, the other patients on maintenance therapy. And if you look at the greater than equal to 1 systemic corticosteroid fill, the SABA patients are receiving more systemic corticosteroids. The other patients are receiving more corticosteroids once you're getting to higher systemic corticosteroid fills. But if a patient is having an exacerbation a year that requires oral corticosteroids, they really shouldn't be on SABA only, and you can see 60% of these people were on SABA only. Now, the safety threshold, I'll show you some data, is about 500 milligrams over your lifetime. And you can see here that, 16% of the patients who are on SABA monotherapy and 21% on SABA plus maintenance have already exceeded their lifetime threshold in 1 year. And then there are the other folks. And actually, our children get the most oral corticosteroids, which is really detrimental to them. This just shows you that the more SABA fills you have, the higher the odds ratio of being exposed to oral steroids, and that you have about 2 times the risk of getting exposed to oral corticosteroids. So the data helping us to understand perhaps the risk of OCS was this one study really made a big impact in 2018. And they took patients in a large UK claims database. They took patients with asthma that had never been exposed to steroids. And then they looked at their data for the next up to 8 years of follow-up and subdivided people on the basis of whether they ended up getting steroids or not and how much they got. And then they compared the people who didn't get steroids to the ones who did in a dose response fashion. And you can see that our steroids are highly effective after about 500 milligrams at giving you multiple non-asthma comorbidities. And that increases over time. And think about some of your patients getting 4 courses a year. So 1 gram is 4 short courses in a year, and we very quickly get there. This schema here is just showing you how quickly you can get to 4 courses. So, to 500 milligrams. So if you give a patient 50 milligrams for 10 days, they already exceeded their maximum. If you're maybe a little more judicious in how much you give the patient, or you use a shorter duration, it may take you a little bit longer. But by the third burst, most of our patients are well above the cumulative systemic corticosteroid dose that causes multiple comorbidities. And we know in some of our asthma studies that when you treat patients and they stop receiving systemic corticosteroids and their asthma gets better, these issues don't resolve. They're still diabetic, they still have heart failure, anxiety, depression. So, once the horse is out of the barn, we often can't get it back in. Our systemic and oral corticosteroids cause a lot of adrenal insufficiency. The more adherent you are to inhaled steroids, the higher the risk of adrenal suppression. And so we want to be able to dose patients with medication when they need it, but not all the time. And if you look at the anti-inflammatory reliever studies, people are getting about 20% of the ICS exposure they would have gotten from regular maintenance therapy. And so now we'll talk about remission and treatable traits. So what we are talking about here in terms of treatable traits is we want to maybe get away from arbitrarily dividing patients with airway disease into buckets, and we want to look at how that disease is being manifested. So the pulmonary traits are going to be people who have infection, inflammation, eosinophilia, obstruction, cough, or reflux hypersensitivity, people who have mucus hypersecretion, and people who have hypoxemia or hypocarbia. Now, that's much more common in COPD. And then the behavioral things, smokers, environmental exposure. All our patients are complaining about air quality in Michigan right now. People with breathing disordered patterns that are they're not physiologic in nature. People with poor inhaler technique or issues with regards to that. And then your extrapulmonary traits are cardiovascular disease, deconditioning, sleep apnea, obesity, reflux, rhinosinusitis, vocal cord dysfunction, anxiety, and depression. So you need to think about all those traits that a patient may have, target them collectively as you treat the patient to improve outcomes. And so what a proposed way of incorporating this would be, it's like we are going to take a patient that's not well controlled, and here is an example of a definition of what that might be. And then you're going to divide them on the basis of biomarkers, and the high biomarker patient with airflow obstruction might be the patient that requires bronchodilator therapy, versus the no airflow obstruction patient might be better off with inhaled corticosteroid therapy, escalating to a biologic in the absence of bronchodilators because they don't have changes in airway caliber. If you're a low bronchodilator patient, maybe we are looking at these people as having more infection or mucus hypersecretion. Perhaps those patients, particularly this would be more pertinent for COPD, might not be people who really need inhaled steroids. Maybe they just need bronchodilators and macrolides. And then if the patient doesn't have either of those, you need to be thinking about what the issue might be and addressing it. So these are some of the things we're thinking about in the future about how to take all this information we've learned and apply it to clinical practice. So lastly, we'll talk about exacerbation. Remission. So it turns out that the way people respond to biologics is multifaceted. Some people hit all four: exacerbation, OCS-free, symptom control, lung function. If you're able to achieve the top three and stabilize your lung function, that's what we call clinical remission. And we usually look at it about 12 months after initiating therapy, and we want that to be sustained over time. And this is something we want for patients. We don't want to wait for lung damage and all kinds of comorbidities and people remodeling before we accomplish this. And it turns out the people who are most likely to achieve remission are those that are young, that have had shorter duration of illness, preserve lung function, and a lower BMI. So the patients who are relatively normal to begin with, and high T2 markers are the most likely to respond very well to biologics. And you can see we've used these composite outcomes as post hoc analyses of multiple phase 3 studies, and also registries like Chronicle and the Danish registry and REDIS. And what we find is that about 30% of our patients are able to achieve clinical remission on the basis of these definitions of achieving extremely good control of symptoms, no exacerbations, no oral steroids, optimized or stabilized lung function. And we hope that in the future will become a little bit more like rheumatologists. You come in with your new RA diagnosis, we risk stratify you. You have T2 inflammation, treat you with our ICS. If that's not working and the patient is rapidly deteriorating, escalating them quickly to targeted therapies, which is what they do now. They introduce sometimes biologics quite early in the course of disease. So in summary, our asthma phenotyping is important. Look at that slide, try to understand what the different mechanisms are because we are actually targeting those mechanisms. We really need to focus on SABA use, and we need to embrace new strategies, including anti-inflammatory relievers. When you look at people who've died of asthma, about 20% of people who die of asthma had no symptoms 3 months before they died of asthma. So, people who are considered, quote, mild are not without risk in terms of having very severe exacerbations, including ones that can be near fatal or fatal. And then we really need to embrace systemic corticosteroid sparing strategies. That includes not giving as much steroid. If your patient comes in, I use peak flow. If it's not gone down by more than 20%, then I'm not going to give you oral steroids. We often are treating symptoms that patients are calling and saying, I'm coughing and I'm short of breath, but we're just giving out oral corticosteroids. We need to be a little more judicious. Are we treating inflammation or are we treating a cough? Are we treating an infection? Do we really need systemic corticosteroids for everyone? And if we do, what dose do we need? And I think giving people inhaled corticosteroids at the right time will hopefully spare a lot of patients systemic corticosteroid exposure. And then lastly, we need to have a paradigm shift in how we embrace asthma care. We're going to become more like our cardiology colleagues and do risk stratification, mitigation, and really start thinking about remission as a treatment goal. And so I want to thank all my teams. This is just my research team at the University of Michigan, and then Inhale, our statewide QI program. And without all these people, I wouldn't be able to do what I do. So I'm happy to take any questions that you may have. Thank you.
Thanks for that outstanding talk. You alluded towards the beginning of your talk about using imaging more in the future. Can you say a little more about that, please?
Yeah. So, we in asthma care, we currently don't do very much imaging at all. Most of us will do a chest X-ray to rule out any comorbidities, and we might image people who have abnormal findings or on exam, or, we really are very limited in how we use imaging. However, there are some things to consider when it comes to imaging. So one, we are increasingly getting these techniques that can tell us how much air trapping people have. And so being able to identify significant air trapping is important because some people have more small airways than large airways disease. In severe asthma, understanding who has mucus plugging is really relevant to how they do and perhaps what treatment they might respond better to. Sometimes you're quite surprised and you find bronchiectasis, and actually that patient is behaving more like a CF patient, a chronic bronchitic patient. They have more infection, and so they need to really be treated a little bit differently. And then we've started actually looking at morphomic markers, chest wall morphomics, and muscle measures and things to inform our decisions about whether a patient has extra pulmonary issues related to their symptoms and whether we can use morphomics to predict outcomes. So I think imaging is going to really become more and more prevalent at the University of Michigan. Anyone who gets an inspiratory expiratory CT for obstructive lung disease gets a post-imaging reconstruction that actually tells us if they have small airways disease. It calculates the function of small airways disease score, which is very helpful Because you might have someone with a normal chest X-ray, they're complaining all the time, your FEV1 is normal, but we don't do a lot of oscillometry testing and we don't look at small airways very much. And those people might have much more small airways obstruction as the early signs of disease before they get large airways obstruction.
Thank you. I enjoyed that. I feel like the paradigm shift would be easier for me to make if you could convince me why I shouldn't wait for them to have their first exacerbation.
Yes.
Are people dying on their first exacerbation?
They are sometimes, you know, if you look at people who died of asthma, the most common reason, the most common feature is overuse of short-acting beta agonists. And in the state of Michigan, we have about 120 people a year who die of asthma, and not about 30% of children. And, you know, we have there, and the problem with asthma is that, you know, if you really look at the whole population, you're going to have quite a few patients that are relatively, quote, benign in their course. So they might have symptoms rarely with exercise. But in that group of undertreated people, there are also people who have very high inflammatory markers. And when they get exposed to the right virus or environmental exposure, can end up in the ICU. And in fact, most of our ICU patients with asthma are not people who are on a bunch of inhaled therapy. And so I think where we are hamstrung, which is what exactly I believe what your question alludes to, is that we are all convinced that the first MI may be the last MI and you may die of an MI. We all embrace the idea that an MI is a bad thing or a stroke is a bad thing. But we've somehow normalized exacerbations. Like, well, do people die of this? Is it important? I think it's quite consequential because you get oral steroid exposure. Even if you don't die, you go to the ER, you go to the hospital, and these patients ultimately over time get loss of lung function and remodeling, and then they become those 45-year-olds with FEV1s in their 40% range, and they're now disabled and can't work. So the consequences are not always so obvious, but I think they're cumulative over time. And what we really need is a way to pick out those really, really low risk patients, and we need some better techniques. And I think the safest bet would be the low eosinophil, low nitric oxide. I just have a little cough with exercise person. You probably don't have to worry as much about that person, but the rest of those patients are really so heterogeneous, and currently we treat them all the same.
We're going to wrap it up there. Thanks for that incredible talk. And I just want to make a quick announcement that the talk tomorrow for pulmonary grand rounds is not the same talk. So those of you who are here and online, come back tomorrow morning for her second awesome talk.
Thank you so much.
Auditorium.